So welcome back. Our next guest speaker is Professor Ken Butcher, who will be discussing the changing face of acute stroke care. Professor Butcher is the Director of Clinical Neurosciences at the Prince of Wales Clinical School at the University of New South Wales. He is a clinician, scientist who has dedicated his career to improving treatment and outcomes in stroke patients. Prior to relocating in Sydney, he was a tenured professor at the University of Alberta and held a Canada Research Chair in cerebrovascular disease. He has held continuous salary in grant-in-aid funding related to stroke research since 2006. And as we heard before morning tea, stroke research is very much his passion. He has produced more than 180 peer-reviewed publications. Please join me in welcoming Professor Butcher.
Thank you, Michelle, and now let me formally say thank you for the kind invitation. It's a privilege to be able to come and speak with you today. I must say I did share this with Michelle before. I had a little bit of trepidation about preparing this talk because although I speak a lot, I'm generally speaking to clinicians and clinician scientists and not survivors of stroke about research. So I've attempted to create something I hope that's interesting. So what I thought we'd cover today, I'll just show you on a slide here what we're going to cover and what we're not going to cover today, which is we're going to start with where I think of the journey of stroke treatment, right? And so I usually meet patients here at this point where we diagnose a stroke and hopefully treat an acute stroke. And then my other job is preventing the next one. We call that secondary prevention. Ideally, in a perfect world, there's something called primary prevention, which I haven't put on this slide, which is what your physicians do before they've met me. To actually prevent the stroke from ever happening. Because ideally, you'd like never to meet me, except maybe on the street. And even then, don't know. And then the third part of what happens, and this is the part of the journey, the patient journey that you're all familiar with, is how do we optimize recovery after stroke? And that's the part I'm not going to talk about today. In fact, I'm really going to restrict the talk, as I was asked to do, to the acute phase of diagnosing and treating stroke. But the other two areas are important, and in my opinion, really the heroes of what happens after stroke are that bottom right, the people that helped you learn to walk again, learn to brush your teeth and go to the toilet again by yourself. And of course, the people like you who went through it all, the much harder job. I have a relatively easy job, which is medical. And I have tools to help me with that, which I'll show you. I think you all know this. I think you know that stroke is a very, very common problem internationally. The types of treatments you have available to you do vary from around the world. And although, as you've discovered, we do have a long way to go, we are actually very fortunate in Australia. You can imagine relative to other parts of the world, we are really at the cutting edge of what's available. And in particular, one type of diagnostic approach we really, really do well in Australia and in New South Wales particularly, which I'll share with you today. In Australia, we're not having one every 3 seconds, but there is a patient suffering a stroke every 19 minutes, which is just reflecting our population. And about a third of those will die within a year. And we say a year because it's not like a heart attack, right? Well, MI or a heart attack, which will often, if you are going to die from that, you're often going to die pretty early on. With a stroke, as many of you know, it's not a quick death. People who die from stroke die because they were immobile for much of a year in a nursing home and then die of a complication after that. And about 1 in 3 people will need some level of support, meaning they didn't return back to their level of function before stroke, which I think you all know. And something that people often forget, although stroke is most certainly a disease of the aged, it often will affect people of working age as well. Now, I just have a few slides. They're fairly sciencey, and maybe for some of you they're Coles to Newcastle, and you already know this. But these are actually slides that I use to teach stroke to medical students, and I'll slow down. But stroke is a funny term. It's a very old term. And it doesn't really describe necessarily what the condition is, right? And it really comes from a time when we didn't know what was happening, right? People just were okay 1 minute and not okay the next. And there was a time you couldn't diagnose stroke. You couldn't look at somebody's brain, and we'll talk about that in a bit too. But stroke actually refers to, in broad categories, 2 types of things: ischemic stroke, which is a blockage of a blood vessel, and hemorrhagic stroke, which is bleeding into a blood vessel, which I talked about earlier. I'm really going to talk today about ischemic stroke. Not that I don't care about hemorrhagic stroke, as you just heard, but because I don't have a lot of time. Ischemic stroke's the more common one. And really what makes my job possible, what the reason I can stand here today and the reason we can treat stroke patients is something we kind of take for granted, but it is really a miracle of modern engineering, which is this thing Dr. Evans is standing in front of here, which is a CT scanner, which all of those of you in the audience who've had a stroke are familiar with, because you've been in that at least once and probably more than once. But that is really the only way we can differentiate these 2 types of stroke. So you can see the ischemic stroke on your left, that dark area on that patient's, that's the right side of that patient's brain. It's flipped on your screen. And the white stuff is blood on the right side of the other patient's brain. In my lifetime, right, this became possible. When I was born, and even when I was in training, probably pre-medical school, this was not routine. Right? The only way to actually differentiate these 2 was to have a neurosurgeon open the skull. Not very practical, and not very useful for treatment, right? And this really is a miracle of modern engineering that we just take for granted now. But it is what makes treatment possible. Now, CT is something we can do very quickly. CT scanners are generally located very close to emergency departments, which is very handy because they're also used for evaluating trauma patients. We use the CAT scan or the CT scan to look first at the brain to see if there's blood. Sometimes we see some early changes associated with stroke, but most of the time early on, we don't actually, if you have an ischemic stroke, there's not a lot to see. And it used to be, when I started my career, it was, well, it looks like a stroke and there's nothing here, so we're going to treat it like a stroke and see what happens. But in the last 10 years, a lot has changed. And although we used to have to fight a lot for these, we had to fight with our radiologist to say to them, we'd really like to see the blood vessels, and you have a technology, which is called CT angiography, which is basically a CAT scan where you get that dye injection. And most of you, if you've had that, you'll remember that hot feeling that you had when it went into your arm, and that flushing feeling, and then maybe you felt like you weed your pants. That was the dye or the contrast agent. And what that does is it fills up the blood vessels. I do have, no, this pointer isn't going to work there, is it? So, well, I've got an arrow pointing at a blockage of a major blood vessel in that patient's brain there. And then the third thing, which is really, really valuable, is we give you another injection, and we can actually see the blood flow in the brain. And this used to be something that was only possible with nuclear medicine scans, PET scans, which are not practical in the acute stroke setting. But this will actually tell us what's at risk and what we can potentially save and what maybe we can't save. And it's really changed the way we approach stroke. Now, when we treat stroke, and it looks like I can't spell arteries, but take out that E there. It's really simple, right? And like I said, that fixing stroke after is so much harder. It's trying to fix that broken computer, right, with all those wiring, and it's above my pay grade. But actually treating stroke early on, pretty simple. It's about plumbing, right? You have blocked arteries, usually blocked by a blood clot. And what I'm showing you in that little animation there is a blood clot that's blocked an artery and stopped flow. That's what happens when you have an ischemic stroke. And we have two ways to open the arteries. One is to use this clot buster drug you've heard of, which is sometimes called TPA, sometimes called Alteplase. But what it does, it's an enzyme, it's a natural enzyme that we all have in our body. And this drug is basically it doesn't matter. It's basically a purified form of your own enzyme that when we inject it into the bloodstream, will break down the blood clot and hopefully open up the blood flow and minimize the effects of the stroke. The other thing we have is a procedure called endovascular clot retrieval. In some parts of the world, you may see this referred to as a thrombectomy, right? So thrombus is clot and ectomy is to remove. And that's what I'm showing you there. It's hard to see, but that's one of the radiologists that I work with. That's clot stuck in the little stent triever, it's called, which you see there on the left. And that's done with an angiogram. So that's a little more involved. It takes a lot more skill. It's not as easily administered, and it has to be done in very specialized centers with specialized personnel. But it is much better at removing very big clots that are proximal. And ideally, ultimately, what we're trying to do with both of these treatments is minimize the size of the stroke. And the way we determine the best way to determine the size of the stroke is an MRI scan, which again, some of you may have had. That's the tunnel, the noisy tunnel, which not everyone loves. But the reason we do that is it gives us the best view of the stroke. And that white area there is the stroke that this patient ultimately had. But you can see if you look over at that perfusion scan, that green area was what would have happened if we'd not removed that clot. But because we removed that clot, that patient ended up with a very small stroke corresponding to that red area there. And that's the best that I can hope to do in the acute setting, right? That's what we're hoping to do. The big stroke on the left would leave you permanently unable to speak or have impaired speech, aphasia, which many of you are familiar with, and probably unable to use your right side effectively. The stroke on the left is a much smaller stroke that you would be able to make a good recovery, and most patients would go home and resume their normal lives after that. So I'm just going to skip over that scan. That slide that doesn't need to be there. So in Australia, right, like I said, we've got really good therapies, but we're probably still missing out on half the patients. There's lots of reasons for that. There's failure of implementation of guidelines. There's failure of implementation of systems as part of it. Part of it is not being able to get to where these treatments can happen in time. And that particularly affects people in regional Australia, and regional New South Wales is no different. We're no different in this state here. Ironically, patients in regional areas are actually more likely to have a stroke, probably related again to access to healthcare in general, primary healthcare, primary prevention. There's probably other factors too, but regardless, they have more strokes, and when they do have a stroke, they have worse outcomes. These therapies that I've shown you, they were all developed in ivory tower centers like the one I work in, like the ones I've spent my entire career in, right? And you could almost measure your probability of getting access to those therapies by the distance of your house from one of those hospitals. And there's that geographic inequity. And that's been recognized. And in New South Wales, it was recognized in 2019 as a problem that would be addressed. And there was an election commitment in 2019 to establish a program aimed at addressing the inequities of care and addressing a lack of access to timely treatments for stroke in regional New South Wales. And that's the New South Wales Telestroke program, which I have the privilege of being the medical director of. And it was planned as 23 sites, and I'll show you where we're at a little later in the talk. And these are the 23 sites. Basically, to treat a stroke, you need to have the CAT scanner, right? Right there. You need a CAT scanner, and you need people that are interested and engaged. And we have those people at those sites, and you can see we're actually, Dr. Ang and I are with Fiona Ryan, and that's either Orange or Bathurst, because she works in both, and I never remember which it is, but we're doing a site visit out there. And the top video is actually a picture of the training that we did to get people ready. Now, you can imagine places like Orange and Dubbo have limited capacity to employ and keep busy people like me. So the solution is actually to bring people like me to those centers when you need it virtually. And that's really what the Telestroke program is about. This is our model of care. Traditional telestroke programs, including the one I was involved with in Canada, usually what you do is you'd have one hospital with a few people providing 24/7 service to a few hospitals around that hub. That's a traditional, what we call spoke and hub model. We're actually tackling a much bigger problem here. We're tackling the whole state. 23 sites is bigger than any telestroke program anywhere in the world. In addition, in New South Wales, as I told you, most hospitals like mine have one, maybe two. RPA has a few, but most hospitals only have, two or less stroke specialists. So what we've done is we've gathered those people who do stroke for a living, and there's 11 of us. That we're not the only 11, but we're 11 that do full-time stroke, and we're down there, and we've said we're going to be a virtual team. So we're scattered throughout the state. We're not even all in Sydney. But what we do is we commit when we're on call for telestroke to do nothing else. We put the rest of our jobs on hold, and we look after patients in the telestroke service. What happens is if you show up at one of our 23 hospitals with stroke symptoms, you go through a screening process, and then they call 1-300 and they call us directly. You don't talk to an operator, you don't talk to an ambulance dispatcher. The physician, the local team at the local hospital is speaking, if I'm on call, to me directly. And if it sounds like a stroke, we'll go to the CT scanner. I'll show you what we do, but we'll basically get those images I showed you. We'll stay with that doctor virtually using, it's the Skype for Business platform. Many of you are familiar, I think, with video teleconferencing these days. So that's essentially what it is. It's a teleconferencing platform that we can see the patient on, and we can also see all of the images on. And at the end of that consultation, we'll talk to family, we'll talk to caregivers that are there, and I'll show you what that looks like in a minute. And if it's appropriate, we'll administer the clot-busting therapy. And if it's also appropriate, we'll say, look, you've got a really big clot. We think we need to get you out of there. We think we need to get you to the closest center where we can get that clot out. And there are 4 centers in New South Wales that do that 24/7, 3 of them here in Sydney. So here are the implementation visits. As I was saying, we put a lot of time and effort into training this, and this was a difference. I know a lot of times it's popular for physicians to complain about health administrators and health services and departments, but I have to say this was an area, project, I think, where they really came through. They really saw the need. They really put the investment in there for the time and the people to make it possible for us to go out to these places and make them understand how important this was and make them understand the need to follow the process, which was adherent to the guidelines. We went through all of our pathway, how to activate the pathway, how to get to us with them. We trained them how to assess a stroke patient, Many physicians don't know that. They're taught something entirely different in medical school than the approach we use in the modern stroke world. And then we gave them some tools. This is something called the acute stroke assessment protocol to help them identify stroke patients and differentiate them from non-stroke patients before they called us. And I'll show you why that's important in a minute. And this is stuff that's important for clinicians, but one of the things that we actually have helped them with is their documentation. Remember I told you I've spent a lot of time going through observational research and going through charts and the records, and often it's abysmal because people have not kept good records because they didn't know what was important to write down, what was not important. And we've automated that process for them to ensure, well, we've not automated it, but we've helped them. We've given them tools to make sure they get the right things into the medical record. So what you've got here, you've probably sort of pictured this. You've got this pyramid where you've got patients coming to a hospital. They're going through a screening process first with this online tool. Then they're going to call us. We still might not take them to a full consultation, and I'll show you why in a minute. And then the people that we actually end up seeing with this consultation, most of them end up having a stroke, and then they get everything. We're not trying to be all things to all people, right? We're not trying to be general neurologists. We're not trying to treat people with, or see people with mini strokes, TIAs, not because they're not important, just because there's only so much 11 people can actually do 24/7 when you're looking after that many people. We're talking about a population of over 4 million people in the regional areas. But basically, what we find is about 1 in 3 of the people ultimately that presented to these emergency departments through these screening steps end up at the consultation level. Some of them are screened out at these 2 different levels. And some of you are probably wondering, why are you screening out patients? Well, I'm going to show you why. This is something there's a question there because when all my medical school lectures are now online, so I use something called Slido, which is always fun to do, so people have to answer online what they think. So just, I didn't give you a Slido and I won't ask you, but I want you to watch this patient, this lady here, and I want you to tell me if you think she's had a stroke. Have you got the audio on, guys? You're not showing the audio. Yeah, that was... What's that? Give you a moment? You want me to back up? I'll back up. All right, we'll try it again.
CBS 2's Serene Branson is live at the Staples Center with highlights and backstage coverage we're seeing for the very first time. Serene.
Well, a very, very heavy debatation tonight. We had a very Darrison, but let's go to Terrace and look for the head of the pit.
So that happened. That's real. You can look that up on the internet. So what does she have? Well, she has aphasia, right? Which I think a lot of you are very familiar with because some of you are dealing with the aftermaths of aphasia. And a very common cause of aphasia is stroke. But the reason I put her there is there are things that look like stroke that aren't stroke. That young lady actually had a migraine, which is a mimic of stroke. And it's one of the things we have to deal with, right? When we're having all of these patients come in is we have to sort out who's having a stroke and who's having something that looks like a stroke. And that's why we have these screening tools in there. Now, in truth, if Serene had come to Orange with those symptoms, she would have made it right to the top and she would have had everything and we would have said, you haven't had a stroke. But that would have been very reassuring for her to know, right, in real time, rather than waiting till the next day, getting transferred to a city and then then getting an MRI scan and then being told you don't have a stroke. And sometimes I think we forget about that. You know, the importance of giving people information early on. It's a stressful situation. You don't know what's going on. Of course, you're thinking you have a stroke. But the patients that don't have a stroke also need to know that. So what we do in our protocols, we actually do all the imaging that I told you about on everyone. This is something that's very unique to Australia and in New South Wales, that we do everything. In many other centers, a physician will come in and say, well, on this one, I'm going to do a CAT scan. I'm not going to do a blood flow scan. I don't think it's going to change anything. We've said we want one process for everyone. We want to do the best test first, which we think speeds things up. But more importantly, and sorry, this is pretty sciencey. I'm just proud of this because this just got accepted for publication in Stroke. But this is our first 1,000 patients that we looked at on the telestroke service. And we found that by doing that blood flow scan, we were able to diagnose at the time of the stroke, a stroke definitively in another 20% of patients. So 1 in 5 people were able to say, yep, that's a stroke. And sometimes it resulted in a treatment. As you can imagine, these treatments are not risk-free when you give a clot buster. You want to make sure you're giving it to the right patient. And it gives us a lot of confidence to be very aggressive with our treatments. This is really what the consultation looks like. And sorry, this is far too complicated a slide. I apologize. This is for clinicians showing how we go through the imaging with the physicians on the ground who are not going to be au fait with all of this stuff because it isn't what they do every day. Right? So we're educating them as we go, and we're showing them how that corresponds to what the patient's having and why we're making the treatment decisions that we are. And I really need to find a better picture of James in his nursery there. And again, we document that in the patient record. So it's as if I was in Orange, or if I was in Bathurst, or I don't know why I keep saying those two places, Shoalhaven, Moree, and I was there doing a consultation. And it's in the patient's record, and here's my recommendation, and let's get the treatment going. And it can make a difference. You've probably heard a lot, and you will hear later today a lot about clot retrieval. Clot busters are really important in the regional setting because we can get them going early. Right, and I'm going to just show you the outcome. I'm going to let her speak for herself. But this was a patient that we treated very early on after this telestroke program was started. She was in the mid-north coast. She was in Coffs Harbour, so she's a couple hundred kilometers away from the closest clot retrieval center, which is actually Newcastle, John Hunter Hospital. Right. By the time she got to Newcastle, her symptoms had got better. And this is a lady who had aphasia. She couldn't talk at all, right? And they were so impressed by how much better she was that they repeated her imaging and her blood flow had normalized. So you can see that's, if you look on your left, she had a big area at risk. She was going to have a big stroke that was going to leave her permanently disabled. And I say disabled because when you see what she does for a living, you'll understand why.
In the aftermath of a stroke, every minute before treatment increases the risk of permanent disability. Now, a new service developed by New South Wales Health is bringing life-saving care to patients battling time and distance.
Good morning, everybody. Good morning.
Back to school after a massive stroke.
Hey guys, I want you to write this heading.
I woke up, I couldn't speak properly, but I managed to phone my friend Trina.
I called 000 and the ambulance picked up Melinda in a jiffy.
Critical timing.
Every second does count.
And cutting-edge technology called telestroke had schoolteacher Melinda Laverick back in her Coffs Harbour classroom in 2 months.
Within 30 minutes of her arriving in the emergency department, we had her in the CT scanner and we obtained these images of her brains. And we could see the area where blood flow was blocked.
Yet Professor Ken Butcher was 540 kilometres away. Using the revolutionary telestroke technology to fully assess her remotely via audio-visual link, he was able to administer the correct clot-busting drug.
Even though your local hospital doesn't have specialised treatment, this telestroke allows you to have it.
And, I think nothing speaks, better to the treatment than the patient who's actually recovered from the stroke. And as you can see, she's back teaching, which is the best I can hope for. So where we're at now, I'll just give you a quick update. We're almost implemented fully. We have 22 sites live, and next week, the last site, Broken Hill, will come on board. Each of those circles corresponds, the size of the circle corresponds to the number of patients we've assessed and treated at each of the centres. So Mid-North Coast are big centres, but they were also the first 2 cabs off the rank. But we're over, this is already out of date, but we're over 2,000 patients treated. in the last 2 years. The majority of them are ischemic stroke. This is a very complicated diagram, and I can see I've used a lot of my time with our AV difficulties, so I'm going to skip over it. But suffice to say that we're treating a high number of patients, right? It doesn't mean they're all getting instantly better. It's still a tough disease, but they're getting the best treatments that we have. They're getting some type in 1 in 3 patients, a little over 1 in 3, they're getting some type of reperfusion therapy, meaning they're getting clot buster, they're getting clot retrieval, or they're getting both in many cases. We track our assessment as we go, our performance, sorry. So we track all of our times. You heard me say time is important, and it is, right? Once we've identified a stroke, it's really important that we do things quickly and we don't muck about, right? And that's why we track all of our times. We review them together as a statewide team. Everyone, the nurses, the doctors, the project officers, everyone involved, and we get together and we say, what went right, what went wrong, what can we do better? And that's all I'm showing you right here. That's our meeting, which again is done on a teleconference. And you know, we're aiming for a door-to-needle time of under 60 minutes. We're currently at 66. If that sounds bad, wait till you hear about my hospital, right? In metro centers. We've actually, our centers have been recognized internationally with the World Stroke Organization Awards. Many of our centers in New South Wales, these are centers that very rarely, and in some cases, never gave a stroke treatment to a patient, right? Like Deniliquin before our program, Shoalhaven before our program, never gave a treatment for stroke. You had a stroke, you went somewhere else. You got in an ambulance, and some of you have had this experience. Go to one hospital, then go to another one, then get a stroke diagnosis. Oh, too late for treatment, right? And these patients, these centers are getting recognized at an international level for their performance, for the number of patients they've treated, but also how fast they're treating them and how effectively they're treating them. And those are all of our telestroke sites that have won gold and in some cases platinum awards. And those are the teams that are involved. Now, the reason we emphasize this is, once you've got that blockage, you are losing neurons quickly. And we want to get that artery open very, very quickly. But there's a couple things that have changed. We've actually started to replace you. Some of you have heard about this 4.5-hour treatment window. We're actually using that less and less. And again, that's the benefit of that blood flow imaging I showed you. We're actually now starting to recognize that patients, if you've got a salvageable picture, which you've got right here, lots of green, not much red, it doesn't really matter if I haven't seen you, if no one saw you for 12 hours, right? You've got salvageable brain, and we should try to open that artery. And we've come to recognize that, and more, we're actually giving both therapies to those people. Conversely, if you don't have a lot of salvage, that's also important, a lot to salvage, right? If you've got a big stroke and you're not going to benefit from opening therapy, and you are in far western New South Wales, does it really make sense to put you in a helicopter, take you away from your loved ones, out of your town, bring you to Sydney or to Newcastle to have a scan and have nothing done? It doesn't. And it's actually an important part of care to keep families together at that time. So I'm almost done. The last thing I'm going to leave you with is we introduced this program with the idea that we would bring regional programs up to the standard of the metro sites, what we're doing, what we thought we were doing in Sydney. What I can tell you is as we've started to look at it, we're actually not doing so well and I'll speak for myself, even in the metro centers. And in fact, we've determined that you're actually getting a better level of care at these regional sites because you're seeing a specialist. You're not seeing a trainee. You're seeing that person within minutes of hitting the door, and you're getting the best therapy, the best evidence-based therapy, guideline-based therapy that you can get. And that doesn't always happen in our metro sites, right? In our metro sites, the professor's at home. He or she takes a phone call. There's several phone calls back and forth. They don't actually generally see the patient. And what we've actually started to do at the host site of Prince of Wales is to try to introduce the telestroke model into the metro model. Because really, why should you have any different care? It's quite possible. We have all the tools, and here I am doing it right here with one of our trainees at Prince of Wales. So our door to needle time at my hospital is 89 minutes, right? So just that's where the 66, put that into context. I will leave you with one last video, which I'll just play it.
I was a normal, active person, and within 5 minutes, I was not. I do volunteer work at Vinnie's at the shop, and I went there at 8:30 in the morning, as healthy as anything. Went to open the shop up at 9 o'clock, and I can't remember what happened after that. And then they were able to get the ambulance and ring Terry, and I got help very quickly. They were just wonderful people, wonderful.
We had a TV link with the professor in Sydney, so we sort of had a doctor sitting there. The sister was working on Pam, and the professor was on the screen, and they're sort of talking to each other. And I've been told that with a stroke, if you get at it within 3 hours, you've got a chance. Well, they were there within 3/4 of an hour, and we had this Professor Butcher, who's supposed to be the #1 guy, basically at the bedside within half an hour.
Pam is a patient that you would never forget. Pam is the patient that is the reason we do this. So Pam's a lady who is previously well. She's got a little high blood pressure, she's got a little high cholesterol, but has never had a major medical event in her life. Her scan demonstrated what I thought would be the case was she had a blood clot blocking the major artery to the left side of her brain, which controls her speech. Her husband was there, and I explained to him what was happening, and then I suggested to him that we should administer the clot-busting therapy. In Deniliquin Emergency Department, to put this in context, this therapy had never been given for stroke in the past. This was the first patient, first time this actually occurred. And the nursing staff, because they've been trained so well through the implementation process that we have for our program, were excellent.
Well, the telestroke service has just been wonderful. We get medical treatment straight away. Telestroke is just so quick, helpful, and the people that are involved in it, they are so helpful, and give us advice, and whatever needs to be done, they're there to do it. Thank you, Denny Hospital.
So, yeah, I think Pam probably said it.
Thanks very much, Ken. That was wonderful. And I hope that gives you a good overview of what's happening with stroke services in New South Wales, both in our major hospitals but also through the telestroke service, which really does affect many of our members in rural New South Wales. I'm just going to open up very quickly for one question in the room and one online if we have it. We don't have any online? Sorry? Okay, alrighty. I'll go to Judith because then if we don't have any online, I will go to the other question.
Dr. Butcher, you mentioned that migraine mimics stroke. I have a granddaughter who has severe migraines. Gives a very good example of being highly affected by aphasia, completely paralysed, right down one side. Takes her maximum medication before she even gets to the hospital. She's really quite frightened that she might have a stroke. So are severe migraines likely to turn into strokes?
Everyone's anxious because migraine is extremely common. How many patients in this room have had a migraine? Yeah. So the vast majority of people who have a migraine are not going to have a stroke. There is a very slight statistical increased risk of stroke or migraine with stroke. So people with migraine, but particularly with those are auras. And if you have complicated auras, then you're a little bit increased risk. And most of the risk is seen in younger women who are on the oral contraceptive pill, which is why young women, I don't know how old your niece is, but young women that age who have those types of migraines are told, you should not take the oral contraceptive pill. But in general, people with migraine are more likely to present with a mimic than actually have a stroke. Yeah. And what we tell people is, you only need to go to the hospital if your aura is different than it usually is and it's not going away. Yeah.
No one for line? All right, we might go to the lady just here with the second question, and then we might. Thank you for your service. I really appreciate it.
Yeah, it's okay.
So I've got the two questions here. First is, what are the chances then when we take the patient to the hospital staff and the doctors who are taking immediate care, they will connect us to your telescope center?
Well, I guess not a question I could put a number on, but if you were going to one of our 23 sites and you had stroke symptoms that were debilitating and you went through the screening process, the chances should be 100%. And if they weren't, then we'd be concerned. Now, if you went to another hospital that's not one of our telestroke sites, the care is more variable, but we're working on that. We're working on putting our screening tools into those hospitals too, so they recognize, you know what, you're in the wrong place. We got to get you to one of the hospitals where we can actually treat you.
Because I understand when they're taking via the ambulance, at that stage they don't know whether it is a stroke or not. So normally they take you to the local area hospital.
And again, ambulance has worked with us. New South Wales Ambulance has worked with us to train ambulance personnel are medical professionals. They're highly qualified medical personnel, and they're trained to recognize stroke too. And if they do, they have protocols to bypass.
And what is in Sydney, which is the center, which is, as you mentioned, there are the 4 telescope center in New South Wales. So where it is in Sydney located?
In Sydney, the 24/7, so the round the clock are Prince of Wales, Royal Prince Albert, and Liverpool.
Thank you very much.
What about Central Coast? The area where is it?
I can't hear it either.
Quickly, this will be our last question. Okay.
Where is going? Which one is for Central Coast, Gosford area? Where would be this tele?
Well, Gosford actually is a comprehensive stroke center. They actually have full stroke services at Gosford Hospital, and in fact, 2 of our staff members, Dr. Evans, works at Gosford Hospital and is head of stroke there. So you would just go to Gosford Hospital.
Thank you, Ken. I'd like to thank Professor Butcher for his talk this morning and for coming out from Prince of Wales to be with us today. It was an exceptional talk, and I hope you've really enjoyed his presentation this morning. Thank you, Ken.